So why is safe staffing so important? Access to timely and quality healthcare is a basic human right. Nurses and midwives make up 50% of the international clinical workforce, but they do undertake 80% of the hands-on care. International research tells us that for every patient added to a nurse or midwife's average workload, there's a 7% greater chance of patients dying within 30 days of hospital admission. When there's not enough nurses and midwives on the floor, then care rationing decisions get made by the nurses and midwives when they're looking after patients. There's not enough time in the day, there's not enough time in the shift to do all cares, and so they make decisions about what can be left out. Care rationing, we know, is harmful to patients, and it also creates moral distress for nurses and midwives, and they leave the profession. So what is CCDM? CCDM is Care Capacity Demand Management and was a program that was developed in New Zealand as a result of the 2005 MECA negotiations. At those negotiations, nurses demanded a safe staffing solution. As part of this, a committee of inquiry was formed. The committee of inquiry had members from NZNO, the Ministry of Health, and DHBs. They looked at the staffing solutions that are available internationally. As part of that, they looked at nurse-patient ratios. At that time, the Committee of Inquiry investigated nurse-patient ratios. Nurse-patient ratios can be legally enforced. Many DHBs at the time were also using trend care. Trend care is an acuity system that records patients' need for care. This recording is done by nurses and midwives on the floor. The nurses and midwives that are actually providing the care. These are the only health professionals that are qualified to provide this information. The CCDM program uses this real-time, real patient demand information to calculate the necessary staffing and budget for every ward, for every shift, for every day. CCDM has been externally evaluated twice since it's rolled out and has been found to be an accurate way of calculating staffing that matches patient demand. So where are we up to with CCDM? CCDM's been available to Whatu, the DHBs, since 2010. And the agreement was that DHBs would implement this as soon as possible. So while there have been some really good examples in DHBs of implementing it really well, in the main, the implementation has been slow and patchy, while DHBs still insist on making savings to nurse midwifery staffing. As a result, too many of our members have not seen the benefit of CCDM, and as a result, their work environments and their workloads have barely changed. In fact, and sometimes have got worse. In the last quarter, Te Whatu Ora reported their progress on CCDM. Only 66% of wards that are able to undertake an annual FTE calculation have done so this year. That's about 328 wards out of 540. Also, they reported that only 85% of the program in its entirety has been implemented across the country. Also, many services still don't have trend care, and this is an issue in terms of CCDM. Our members have waited for 12 years for this safe staffing solution, and it's just not acceptable. Our members need minimum safe staffing now. Nurse-patient ratios are enforceable and can provide this, and penalties can be applied for non-compliance. One of the most recent well-researched models for nurse-patient ratios was introduced in Queensland in 2016. The research undertaken alongside the implementation of these nurse-patient ratios showed some significant changes. There were significant improvements to patient mortality, length of stay, and patient readmission. But it also showed that there was an improvement to staff satisfaction and less nurse and midwife burnout. We want immediate introduction of enforceable minimum safe staffing, as per the Queensland ratios. These to enforce both the numbers, the skill mix, and also be implemented across all areas. The core data set is also something we want to retain. The CCDM core data set is a range of 23 measures, and it's a really important way of showing us if nursing is effective and safe. We would like this used at government level, but also available at public level. Once the ratios have been established, more work will need to be done to make sure that they fit our New Zealand context and our cultural requirements.